behalf of Friendsa Hetero Healthcare, myself Priyanka Patil would like to welcome all our eminent speakers and moderator on and all the viewers for the webinar on Carbetocin in Action case studies from the labor room. So moving ahead, I would like to introduce Dr. Prashant Khandeparkar, who is our consultant in hetero healthcare. Dr. Prashant Khandeparkar has done his MBBS from Grand Medical College, Mumbai, and also he has done very other diploma courses like in clinical research and in pharmaceutical business management. So he has a rich experience of 35 years in pharma companies, including the giant companies like FDC, Pramel Healthcare, and Abbott. So currently now he's a consultant with Hetero Healthcare, and his expertise areas is new product addition and have being a support for the medical support to the marketing activities. So Dr. Prashant Khandepakar sir, we welcome you all, sir, and please take the session ahead.
Thank you, Priyanka. Thank you so much. Doctors, today's session, Carbetocin in action. We all know Carbetocin is a drug which is used for prevention of PPH. And PPH is one condition which none of us would like to see. It is more easy to read rather than to experience. But then, as they say, expect the unexpected, you never know what will happen. To discuss this and to give us more clinical insights on PPH management and Carbetocin, we have two eminent speakers today, Dr. Anita Singh and Dr. Amita Sinha. Dr. Anita Singh is a consultant Jyoti Punj Hospital and Jana Chikitsa Hospital. Madam is President AOG SBJ, Chairperson Bihar Chapter IAGE, past President POGS, VP Foxy 2020. Area of interest for Madam is high risk pregnancy, infertility, and endoscopic surgery. Recent award, Legendary Award IAGE 2024. The next speaker today is Dr. Amita Sinha. Dr. Amita Sinha is consultant gynecologist Patna, the Secretary Patna Obstetrics Gynec Society 2023-24, Communicator ISO PARB 2022-24, East Zone Coordinator Practical Obstetric Committee Foxy 21-24, Governing Council Member AOG SBJ 2023-24, Organizing Secretary Foxy PPH Con 2024. Madam has won awards like Foxy Padma Bhushan Kamla Bai Hospital Award 2023. Has many publications in index journals, contributed in chapters in Foxy books, and prepared book lists for public awareness. Madam is life member Foxy, FIGO, ISOPRB, FAO, AOG, SBJ, AMA, IFS, ISR, and IMS. Welcome both the speakers, Dr. Anita Singh and Dr. Amita Singh. Welcome, madam. Over to you for the deliberations. Thank you.
So before starting the session, we would pray Goddess Saraswati. So let us
Audio is not there. Please make it full screen.
over to you, ma'am.
Yes, please stop. I want to share my PPT.
Yes.
On my side, okay?
Yeah.
Is it visible, Priyanka?
Yes, ma'am.
Okay.
Visible.
Good evening, everyone. Respected seniors, our moderator, and all the audience, lovely audience who are watching this webinar. A very good evening to all of you. Now we are going to start today's session, which is on the carbetocin case study and all the details of carbetocin. As you all know that this is the new drug and we have been using for few years for prevention of PPH, and this drug is the smarter, superior and safer choice in PPH management. So I would like to start this presentation by a case study. This is regarding use of carbetocin in vaginal delivery. As we all know that this drug is a long-acting oxytocin analog used to prevent uterine atony and postpartum hemorrhage after vaginal delivery or cesarean section. Here in my case, I'm going to present only one case, and another case will be presented by Dr. Anita Singh, madam. So though she has lots of experience of this molecule in different categories of patients, but we will take only one cases. Both of us will take only one cases. So this is the case of vaginal delivery where carbetocin was used. A patient of 32-year-old, second gravida, with a history of previous PPH in vaginal delivery with episiotomy and assisted second stage. This history is important to note her history. So we decided in this delivery to use carbetocin as there was high risk for PPH due to previous history and prolonged labor. In this case, 100 microgram of carbetocin was administered intramuscularly after delivery of placenta. And finally, we found that there was effective prevention of PPH with minimal blood loss and stable vital signs. This patient was very afraid as she had severe PPH in previous pregnancy, but this time she was very comfortable. So we came to the conclusion that its half-life, as carbetocin's half-life is compared to as compared to oxytocin is so much high. Carbetocin half-life is 30 to 40 minutes, whereas oxytocin has 3 to 5 minutes. That this long half-life allows for sustained uterine contraction and reduced risk of PPH. Many studies have shown that there is reduced need for additional uterotonic agents and blood transfusions with the use of carbetocin. So we should take few important considerations, like it should be administered after delivery of placenta. We always should monitor for hypertension and use with caution in patients with cardiovascular disease. So in one line, carbetocin is a valuable tool in preventing PPH, particularly in high-risk patients, and its effective use can reduce maternal morbidity and mortality and improve patient outcome. This is just an example of one case. Now I request Anita Singh, madam, to present second case. Madam, over to you. Anita,
Thank you, Amita.
yes.
Good evening, one and all. First of all, I wish to thank Hetero Pharma for having arranged this program and invited us to share our experience on the new molecule carbetocin. So, as Dr. Amita has presented a case of normal vaginal delivery, I am going to share my experience with cesarean section as well, that also in a patient who was having twin pregnancy. So, she was a primary gravida, and at 39 completed weeks, as she was twin and the first baby was presenting by breech, I decided to go for elective cesarean section. I was apprehensive about postpartum hemorrhage because she had twin pregnancy as well as she was put up for elective cesarean section. Both are risk factors for more hemorrhage after delivery. So I had arranged blood also, and I had talked with the attendants regarding the risk that can happen to her. But I decided to give her carbetocin, and I had in reserve other uterotonic agents, of course, if needed, as and when needed. So I did a cesarean section, and after the delivery of the second baby, I gave 100 microgram of carbetocin IV. And that led to a spontaneous and complete separation of placenta and membranes on its own. And patient had very good uterine retraction, and there was no PPH, neither there was any extension of the tear. as we have heard from Dr. Amita, that it has got a long half-life time. Otherwise, sometimes the uterus retracts, and after half an hour, that you see that the uterus relaxes and the patient starts bleeding again. So I had a very close watch upon that patient so that she doesn't land into postpartum hemorrhage. But that patient did not have any postpartum hemorrhage, and she was very good even in the post-operative period, which has watched up to 3 to 4 hours. And that patient did not need any other oxytocin because she was not bleeding. She was having a normal bleeding after delivery. So that is my experience with carbetocin, and that acted in elective cesarean section as well as in twin pregnancy. So that is my experience with the carbetocin, and I think it was a very good one. And of
Thank
course,
you, madam.
Yes.
Can we move ahead?
Yes, sure.
Yes. So, because today's meeting is on carbetocin in action, and especially its use in postpartum hemorrhage. So a presentation will be based on some aspects of postpartum hemorrhage, its mortality, morbidity, its prevention, and other details of carbetocin. So I would like to start it from overview of postpartum hemorrhage. So as we all know, this is a daunting event, and it, by definition, everybody knows that per theory, it is a loss of at least 500 ml blood during vaginal delivery or more than 1000 ml following cesarean section. And it is very common and can occur even in women who are not at risk. We were talking about high risk pregnancy, but it can occur in any women who are not at risk. And this is the leading cause of maternal mortality in low income countries and the primary cause of nearly 1/4 of all maternal deaths globally. In this picture, they have shown that there is one case, normal postpartum patient. It is at the up, and below it is patient with PPH. We can easily appreciate that how uterus is relaxed in picture of lower side, and upper it is well contracted. So here there is no PPH, and if it is relaxed, there will be PPH. In picture it has been demonstrated. So postpartum hemorrhage is unfortunate yet common. That's why we say it is preventable tragedy, and we can prevent, we can minimize it, we can handle it, but still it is prevalent in our scenario in our country. Look, if we look at the maternal mortality, leading PPH is the leading cause of maternal mortality, accounting for more than 35% of maternal deaths. If we also see the maternal mortality ratio, it is in developing country, it is very high, but now in India it has also decreased, but per 1 lakh live births compared to very two picture to 16 or 15 or 11 death in 2 digit in developed countries. So we have to go miles to improve our status, though it's not 240 right now in India, but in some developing countries it is high. Coming to global PPH incidence, if we see the global PPH incidence, 14 million women suffer from PPH, and incidence of this hemorrhage is 2 to 4% after vaginal delivery and 6% after cesarean section. PPH incidence in India is 38% of maternal deaths are due to PPH as per health records, and 25% of global deaths take place in India, and 2/3 of these attribute to PPH. So India has an unexpectedly high maternal death of 5 per 1 lakh birth, way up 20 years back. Now it's not so high because we all are using newer drugs, newer treatment. Evaluation has been developed, and we are treating these cases very well. But still we have those cases in rural area and in high risk cases. So let's see what is the impact of postpartum hemorrhage. If some woman suffers from postpartum hemorrhage, there is significant increase in hospital stay, higher inpatient mortality and morbidity, major impact on the lives and health of the affected patient and their families, and there is long-term psychological impact on affected women. Etiology of postpartum hemorrhage. Everybody knows that the 4 T's are famous for the cause of postpartum hemorrhage. That is uterine atony, presence of thrombinocoagulopathies, failure in clotting. If there is uterine trauma, injury, birth canal rupture, inversion, lacerations, that causes. And finally, if there is some retention tissue, retention of placenta and clots and abnormal placentation are the common causes of postpartum hemorrhage. Now, coming to I would like to describe the different causes. Out of these 4 causes, atonic PPH is most common. It is approximately 70% causes of postpartum hemorrhages due to atonicity of the uterus. And what are the commonest causes of atonicity? These are some few risk factors like multiple pregnancy or prehistory of previous PPH or non-placenta previa. Here we found that there is atonicity is very high and it leads to postpartum hemorrhage. There are few conditions which are known as risk factors for postpartum hemorrhage. As in last slide, I also showed that retained placenta, multiple pregnancy, if there is failure to progress in second stage, placenta accreta, episiotomy, prolonged third stage of labor, preeclampsia, previous PPH, general anesthesia, fetal macrosomia, and perineal lacerations. These are the risk factors where we should be alert. If we deal with this type of cases, we should remain alert and we should predict postpartum hemorrhage and try to handle this condition efficiently. But in low-risk populations having vaginal birth, most women developing PPH have no identifiable risk factors. So don't always think for risk factor hoga tabhi PPH hoga, because most of the women developing PPH have no identifiable risk factors. So we must know the management of and prevention. We must know the prevention of PPH. We should try to prevent this disease, and then finally we should manage this condition to prevent maternal mortality and morbidity. Coming to categories of postpartum blood loss. If it is less than 500 ml, it comes under minor category. If it is more than 1000 to 2000, definitely it's major. If the blood loss is, we can categorize it as mild, moderate, and severe. If it is less than 500 or up just cross 500 is mild hemorrhage. But if it is between 1000 and 2000, then it is moderate postpartum hemorrhage. If blood loss is greater than 2000 ml, so it's severe PPH. So what are the clinical, what will be the clinical findings in postpartum hemorrhage that makes one aware to manage this condition urgently and in emergency manner? So whenever there is much moderate or severe postpartum hemorrhage, we find different degrees of shock. There may be blood loss is higher than 1015 ml and 2000 ml. So compensatory mechanism works, but blood pressure start falling. And there is marked fall and profound fall in severe and moderate hemorrhage. Symptoms and signs starts from palpitation, dizziness, tachycardia to collapse or hair hunger, and sometimes anuria also occur. We find circulatory collapse. If there is concealed hemorrhage, increasing abdominal girth, loss of uterine contractions, maternal shock, features of maternal shock, and sometimes it is revealed hemorrhage. We can see concealed abdominal enlargement occurs, and we see the clinical features and diagnose the postpartum hemorrhage. So that to diagnose postpartum hemorrhage is a tricky thing. We must learn how to evaluate the patient. Rapid assessment of patient status is very important. Assessment of vital signs and blood loss, tachycardia, blood pressure, hypertension. We should look for all these things. And in the same time, we should learn examination at the time of hemorrhage, that is assessment of the entire genital tract. We should search for the lacerations, hematomas, or signs of any uterine rupture. Manual examination for retained placental tissue. Assessment with bedside ultrasound to check if the uterus is non-contracted, if facility is there. Otherwise, we should diagnose it clinically also. And evaluation of uterus to check for uterine inversion. Though this is rare condition, but due to wrong way of delivering we see this condition also in our rural setup. Lab assessment, complete blood count to check hemoglobin, hematocrit, and platelets, coagulation studies, and the assessment of fibrinogen are important steps for diagnosing this. But challenges are still there in diagnosing of PPH, because PPH is diagnosed by visual estimation of blood loss after delivery. Vaginal bleeding may be revealed or concealed, alteration in pulse BP, flabby uterus. So these challenges lead to delay in diagnosis. Visual estimation of blood loss volume is not always correct. Many cases of PPH occur without any identifiable risk factor, and the consultant or nursing staff remain relaxed that there is no such high risk factor, so this patient will not have any PPH. So these are few conditions that also poses challenges in diagnosis of PPH, our attitude also. So these are the approach towards postpartum. If there is poor uterine tone, I have already mentioned we should do clinical finding, investigations, management. Trauma management will be different, and retained tissue if there is there. So investigation should be done under anesthesia, and manual removal of retained tissue should be done to prevent to stop the hemorrhage. And if there is coagulopathy, we should do complete investigation. Medical management is there, surgical management is also there. Attempts should be made to identify the cause in women who are bleeding in parallel with resuscitation. This is the take for all the audience. We should not wait for the assessment and management. That should go side by side. You have to identify the cause and you have to try to arrest the bleeding in parallel with resuscitation if the hemorrhage is severe. These are few complications associated with PPH: postpartum depression, anti-pituitary ischemia, which delay or failure of lactation, anemia, fatigue, requirement of blood transfusion, myocardial ischemia, dilutional coagulopathy, and sometimes death also occurs. So what's the how we should prevent this postpartum hemorrhage? So these are different approach for prevention of PPH: readiness by every unit, patient-centric recognition and prevention, respond to every hemorrhage. These are the three key features that we should use for prevention of PPH. These are the few practice of prophylaxis of PPH. Number one is improvement of health status of mother in and during pregnancy. That is, whenever patient come for antenatal checkup to any consultant, we should check her hemoglobin regularly and frequently and try to maintain her hemoglobin up to 11 gram%. Identify high risk women, plan for institutional delivery, strict vigilance of all women in third stage of labor. Most important part, practice active management of third stage of labor in all. Examination of afterbirth should be a routine procedure so that we can identify that is there something left in the uterine cavity or not. Explore uterovaginal canal following difficult instrumental destructive delivery. These are few practices where we can profile for use for prophylaxis of postpartum hemorrhage. WHO recommendation on use of carbetocin has already recommended. WHO recommends use of an effective uterotonic for the prevention of PPH during the third stage of labor for all births. To effectively prevent PPH, only one uterotonic should be used as per WHO recommendation. And the uterotonics to be used: oxytocin or carbetocin, misoprostol, ergometrin, methyl ergometrin, oxytocin and ergometrin fixed dose combination. But as per WHO, to effectively prevent PPH, only one uterotonic should be used. There are few limitations with alternative uterotonic agent like ergometrin, symptometrin, misoprostol. Now coming to active management of third stage of labor, which is the most effective strategy to prevent PPH. We all know the active management of third stage of labor. Its steps everybody knows, so I am not going to go into detail. Like prophylactic uterotonic agents is given after delivery of placenta, cord clamping and cutting. After delivery of baby, and cord clamping and cutting, controlled traction of umbilical cord, and uterine massage. With this, I have to move forward regarding treatment of postpartum hemorrhage, and this section and regarding all the details of carbetocin will be taken by Dr. Anita Singh, madam. So I request madam to go through this treatment of postpartum hemorrhage part and all other details of carbetocin. Madam, over to you. Anita, madam.
Okay. Thank you, Amita. You
Yes.
have very beautifully described the causes. I want to show my slides.
Okay, madam. This is treatment of postpartum. Should I stop sharing this slide, madam?
Yes, so that I can keep on
Okay,
changing.
definitely, madam.
So we have already discussed about the causes of PPH and how to apprehend it, how to prevent it, and what should be the routine practice in the delivery of, in any delivery that you are conducting.
Yes, madam.
Recording in progress.
I don't know why I am not being able to, I mean, are my slides visible?
No, madam. Yeah, can you help, madam?
Is it not visible?
No, madam.
No,
Okay.
madam, it's not visible.
I don't know what is wrong with this. So that slide, those slides are there on my desktop. I have already opened it up.
We can ask Priyanka to share slides from her side, madam, because I have logged in from my mobile now.
Priyanka, can you share madam's slides?
Ma'am, should I share?
Yes, you start sharing.
She is
Yeah.
unable to see.
So from which slide you?
From section
I
3.
think you straightway go to section 4.
Yeah,
Section
section 4.
Okay,
Section 4.
okay.
Section
Yes.
4.
Take a bite.
Yes, ma'am, shared.
Okay. I think it is full screen.
Yes, ma'am.
Okay, thank you, Priyanka. So now we have come to, I think, the most important part. If you have missed to apprehend and to diagnose, now if postpartum hemorrhage has already occurred, how to go with it? Because you have already heard about the complications that it can lead to. Next slide, please. So prevention, we all know, is the first line of treatment. So how to prevent postpartum hemorrhage? By the routine use of uterotonic drugs. Previously, you used to give oxytocin, methotrexate, etc. But now it is recommended that it is better to give carbetocin. We are more sure about its action as well as duration of action. So, and if after having given uterotonic drugs, and assessing what is the cause of the bleeding, because simultaneously you should, as told by Amita, we should manage as well as diagnose and treat. So once you have given uterotonics, look into the vaginal canal, look at the cervix, that it is not torn, look at the vaginal, any of the vaginal tears. And if the uterus is contracted and then the patient is bleeding, then there are more chances of trauma. And you have already inspected the placenta. If it is completely removed, then there are no chances of any tissue behind. And normally at the initiation of bleeding, patient doesn't have coagulation failure if there is no history of coagulation defect in that particular patient. So I think within few minutes you can diagnose what is the reason for bleeding in that particular patient. If it is a atonic hemorrhage, that of course you can go with other agents, like we use tranexamic acid, and as well as we can supplement it with other agents like methotrexate, misoprostol, etc. Or if it is not responding to any of the uterotonics, then temporizing methods can be used by putting in balloon or suction evacuation machine sort of thing to create negative pressure. So uterotonics, prothrombotics, that is tranexamic acid, tamponade, and in the last, if everything fails, then you should think about the surgery. Next slide, please. Previous one, please show me the previous one. Priyanka, show me the previous one. Next. Yes. But you should be able to assess what has been actually the amount of bleeding that the patient has already had. It is stage 0 if it is less than 500 and volume loss is less than 10%. But if it is between 500 to 1000, then there has been a volume loss of 15%. But still there will be no sign and symptoms. But do not relax, because this is a very critical period. If bleeding progresses beyond 1000 milliliter, patient will start having signs and symptoms and can very rapidly deteriorate and can go into shock. So it is the 1000 ml mark, which is the alert line. Alert line is 500 and 1000 ml is the action line. Once the patient has reached 1000 ml of blood loss, you should be in action and start thinking about what to do. At the same time, you should monitor urinary output. You should continuously look at the pulse rate, respiration rate, and any sign of hypotension. Or if the pulse pressure has reduced, even if there is no hypertension, it is indicative of massive amount of blood loss. When the patient has got more than 1500 and up to 2000, she has already lost about 30 to 35% of her blood volume, and that manifests in hypotension, tachycardia, cold and clammy extremities, and tachypnea, and that is an advanced stage of shock. Anything beyond 2000 indicates more than 40% of the blood loss, and then the patient goes into profound shock. So you should always remember the alert line and the action line. That is very important if you want to prevent the complications of PPH. Next slide, please. What are the current challenges that we face in managing PPH? Oxytocin, need to appropriate training to the clinical staff. All the time the clinician is not present. So staff should know when to give itotonic and how to give it. In that way, carbetocin is very good. They should keep it loaded in the syringe, and as soon as the baby is delivered, they should give it intramuscularly. Next slide, please. Why this carbetocin was at all delivered, at all researched out and has been developed? Because it has got the greatest advantage in the form of its heat stability. Because oxytocin was also a very good molecule, but it was heat labile. And that used to have lot of problems. In country like ours, where there is no facility for cold chain maintenance and people are unaware of its importance, by the time the drug reaches in the periphery and even many of the good institutions, you never know what has been the chain in between from the original place from where it has been delivered and by the time it has reached you. So that used to lead to quite a great number of postpartum hemorrhage because of the lost potency of oxytocin. In that way, carbetocin has got an upper hand. It doesn't lose its potency in the normal room temperature. And that is a great thing that they have been able to develop, because previous formulations were stable at 2 to 8 degrees centigrade, whereas carbetocin is stable at up to 30 degrees centigrade of temperature. It is stable. Half-life of carbetocin is about 75 for 24 months. It is maintained at 30 degrees centigrade and even at 75% humidity. So it avoids need for cold chain storage and logistics are simple, and it is also provided in a vial. Next slide, please. Next one. So the time of administration of eutotonics vary and different people practice in a different way depending upon their facility and their choice. It can be given at the crowning of baby's head, but the problem at crowning is sometimes people think that there has been a crowning, but baby takes long time to deliver even after that. So that is one problem. You should be in a very, we should be able to recognize when there is actual crowning that is happening. People recommend at the delivery of anterior shoulder. So the person who is giving the injection, if he or she is very prompt, of course, you can give it at the time of delivery of anterior shoulder. Most of the times it is given, or when it is injected, it is already the baby has been delivered completely. But that doesn't make much difference. Some people even give following the delivery of the placenta. Prophylactic use should always be done to prevent PPH, and after delivery of the fetus, it should be given. One should not wait for delivery of the placenta. Otherwise, the delivery of the placenta can be delayed and the patient can have partial separation of the placenta and can have mild to moderate amount of PPH. It can also be given if the has not been given prophylactically or even one dose has been given prophylactically. Then if the patient starts having PPH, then carbetocin is not repeated, but you can go for other things like tranexamic acid, oxytocin, misoprostol can be given sublingually. It can be given pervaginally also. So all this ergometrin mostly we do not need and do not give nowadays for last many years because it leads to hypertension in majority of the patients. And those who are hypertensive themselves, it can lead to severe complication of hypertension like hypertensive encephalopathy, etc. So one should be very careful before injecting ergometrin to the patient once he is hypertensive or even if there is history of hypertension. Next slide, please. Next slide. So carbetocin is a next generation drug for PPH management, and it is a synthetic one. Therapeutic indications are prevention of postpartum hemorrhage. You can see it is not still indicated for treatment of postpartum hemorrhage. It is indicated exclusively, routinely in all the patients, unless and until there is some strong contraindication in all the patients after delivery as a prophylactic agent for prevention of PPH. Next slide, please. It is presented in 100 microgram vial and will not go into the mechanism of action in detail. There is binding of calcium, There is binding of calcium to calmodium. So I will not go into these theoretical discussions, but a single IV dose of carbetocin 100 milligram administered after the delivery of the baby is sufficient to maintain adequate uterine contraction, preventing uterine atony and any excessive bleeding with efficacy comparable to hours of oxytocin infusion because it has got a long half-life. Next slide, please. Next one. What are the benefits of heat-stable carbetocin over oxytocin? There is reduced need for additional uterotonic agents because of longer half-life, no cold storage required, and it has got similar efficacy as oxytocin, and it has got a very good tolerability like oxytocin. So if you compare carbetocin with oxytocin, onset of action of carbetocin is around 1 to 2 minutes, whereas oxytocin IV acts immediately. If you give IM, carbetocin takes 2 to 3 minutes to act, and oxytocin takes 2 to 5 minutes to act. So in intramuscular, there is no difference almost in the onset of action. But regarding the duration of action, there is a definite difference. IV carbetocin has got 60 minutes duration of action. IM carbetocin has got 119 minutes duration of action, and that is why mostly IM carbetocin is recommended in all the cases of normal delivery, whereas oxytocin has got only an action up to 30 minutes. So if the patient is not able to maintain the retraction of the uterus after 30 minutes, there are chances of relaxation of the uterus, and few patients can have delayed postpartum hemorrhage. Half-life of carbetocin is 40 minutes after IV and IM, whereas half-life of oxytocin is 3 to 5 minutes after IV and 3 to 5 minutes after IM. So you see that a single IV injection of carbetocin achieves uterine activity within 2 minutes of its entrance into the body and lasts approximately 1 hour. Carbetocin can increase the rate and force of uterine contractions. Next one, please. Next slide. So the benefits of heat-stable carbetocin over oxytocin is definite. Carbetocin is 24-fold less potent than oxytocin at the vasopressin V2 receptor reducing the risk of any hyponatremia. So that is another benefit with carbetocin. It reduces any risk of hyponatremia, which can happen with oxytocin. Water retention in the body because of oxytocin can lead to disturbances in the sodium levels. Oxytocin has got an antidiuretic effect, which is not true for carbetocin. And IV infusion may cause water retention, more water retention, and sometimes intoxication if you do not consider the amount of fluid that you have given along with the oxytocin, and that can lead to hyponatremia. Water intoxication has been reported in women treated with oxytocin for PPH, and also who have been given induction or augmentation of labor for a long time with large volume of fluid. And as report says, to date, no case of hyponatremia have been reported in literature with carbetocin. So that is also a great advantage, because we are always very careful while giving oxytocin infusion for induction that you should give less volume and you should monitor the patient. Next slide, please. There are several clinical evidences and there are several studies which show the superiority or non-inferiority of carbetocin as an eutotonic agent if compared to oxytocin and other eutotonic agents. So this is a very important study and very many times quoted, and that is WHO Champion trial. It was done, carbetocin in prevention of hemorrhage, the largest clinical trial in the prevention of PPH. It was a non-inferiority, double-blind, randomized trial. So this is one of the best trials that can be done. Objective was to compare the effectiveness and safety of investigational heat-stable carbetocin to the oxytocin in the prevention of PPH after vaginal birth. Patients enrolled were 30,000 in number, and it was done in different ethnic groups. 10 countries participated in this trial, and the primary outcome of this trial was that proportion of women with blood loss of at least 500 ml or the use of additional eutotonic agents. And second was the proportion of women with blood loss of at least 1000 ml. Next slide, please. So, and the conclusion of this study was that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of any additional eutotonic agents. So it was as effective as oxytocin, not less than that, for any of the parameters that were studied, whether it is loss of blood or whether it is need for any additional eutotonic agent. Next slide, please. So carbetocin is a good alternative in PPH prevention in high-risk cases. Next slide. Next one. Then previous one. Yes. Then it was compared with synthometrin, which is a combination of oxytocin and ergometrin. Next slide, please. Next slide. And it was concluded that carbetocin is more effective than synthometrin. There was significant difference between mean blood loss. With carbetocin, mean blood loss was 224, whereas in synthometrin, it was 306. Better hemoglobin level on postpartum day 1, carbetocin 10.9, synthometrin 10.6. Lesser mean drop of hemoglobin concentration 24 hours after delivery. And there was reduction in postpartum blood loss, smaller drop in hemoglobin level, and less adverse effects. And that made carbetocin more effective than synthometrin. So this study also says that carbetocin is a better molecule than synthometrin. Next one. Next one. Carbetocin, if you look at the safety profile of oxytocin and carbetocin, because these are normally the things that we look for in a drug. So far as the safety profile is concerned, if you look at carbetocin and oxytocin, Vomiting is less in carbetocin. Nausea and vomiting both are less with carbetocin. Headache is also less with carbetocin, as well as leukocytosis is also less with carbetocin. And rest of the parameters that had been looked at almost equal in both the groups. Next slide, please. Next one. So carbetocin has a comparable safety profile to oxytocin. Common adverse events reported are heart disorders like arrhythmia, palpitation. It was 0 with carbetocin, and the percent was of course low, but it was found in few patients with oxytocin. Fall in blood pressure was 0 with carbetocin, and it was seen in about 23% of the patient with oxytocin, and we all know that oxytocin leads to fall in blood pressure. There are also skin rashes because in cases of oxytocin, whereas it was not found in any case of the carbetocin. So there are few things that are good as far as carbetocin is concerned. The heart arrhythmias, palpitation, fall in blood pressure, skin rashes, all are almost not seen with carbetocin, where few patients after oxytocin show all these problems. Next slide, please. Next one. So carbetocin seems to be a promising agent for PPH prevention. Efficacy of carbetocin was checked against conventional eutotonic agents. It was compared with oxytocin, symptometrin, or placebo. Carbetocin is effective compared to other conventional eutotonic agents. A statistically significant reduction in the need for therapeutic other eutotonics, lower risk of PPH, reduced need for uterine massage compared to those treated with oxytocin, lower blood loss compared to those treated with symptometrin. So intramuscular administration of a carbetocin at a dose of 100 microgram is more effective than oxytocin for preventing PPH. Its use is associated with less blood loss, better tolerability profile compared to symptometrin. Next slide, please. Next one. There are several guidelines, national as well as international guidelines, which say that there are benefits of carbetocin for preventing uterine atony. WHO guidelines for PPH prophylaxis comes, oxytocin and carbetocin comes at the second number, and then misoprostol, ergometrin, oxytocin, symptometrin. Whereas SOGC, that is Canadian guideline, that says carbetocin 100 microgram IV bolus, that recommends to it, that society recommends. This RNZCOG, that is from New Zealand, and that recommends active management of third stage of labor prophylactic eutotonics. The name has not been given. FIGO recommends carbetocin, one of the recommendations for PPH management. Germany and Australian societies recommend carbetocin 100 micrograms slowly IV. France FCOG guideline says carbetocin on proving non-inferior to oxytocin. So these are the several important guidelines and it is their opinion regarding carbetocin for the prevention of postpartum hemorrhage. Next slide, please. Next one. Next one, Priyanka. So there is another study, efficacy and safety of carbetocin versus misoprostol plus oxytocin. Because many times we combine oxytocin with misoprostol. Next slide, please. So the combination, the previous one. So the combination has also been used, and the result of that study showed that there was no significant difference, the requirement of additional eutotonics in carbetocin group. It was required in 13% versus 16% in other groups. Pre and post-operative hemoglobin and estimated blood loss were also better with carbetocin. So intravenous carbetocin demonstrated similar efficacy to sublingual misoprostol plus oxytocin inhibition for the prevention of postpartum hemorrhage. Next slide, please. So the key takeaways from this discussion on carbetocin is that Champion trial referred the carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional eutotonic agents. Compared with symptometrin, misoprostol plus oxytocin, carbetocin demonstrates significantly better hemoglobin levels, lower risk of hypertension, and fewer adverse events. WHO, FCOG, FIGO, SOGC, and RANGCOG recommend use of carbetocin in management of postpartum hemorrhage. So in India also, carbetocin is available for last many years, and most of us has gradually switched over from oxytocin to carbetocin in our routine practice for the prevention of postpartum hemorrhage. Thank you very much for patient listening.
Thanks, madam. Thank you very much. We'll take the questions.
Yes, yes.
Is there a specific place where you should use carbetocin over oxytocin for prevention of PPH?
Yes, as madam told, carbetocin is, what was your question? When to use carbetocin over oxytocin, na?
Yeah.
Yeah. Carbetocin is preferred over oxytocin for the prevention of PPH, especially in high-risk patients, where there is
Neutral
history of PPH,
Yes.
multiple gestation,
Yes.
or any type of vaginal anomalies, history of prolonged labor, or in this current scenario, is there labor is prolonged, then we would like to prefer to use this carbetocin molecule. So these three things are very important. And I think cesarean section, carbetocin is recommended after cesarean delivery as it reduces risk of PPH. Atony, that is very important if it is suspected or diagnosed. And one more case, that is patient with bleeding disorders. If the bleeding disorders are present in the patient, carbetocin is recommended for that patient. And in remote area, where in villages, where power supply is not there and temperature maintenance is poor, so in no resource setting, it is also very useful, where we would like to use this molecule in place of oxytocin. And sometimes when oxytocin does not work, then it can be used as second line agent. But madam will give the best comment on that. When oxytocin is ineffective, should we go for carbetocin in the same patient or not?
Hey, madam, you are mute.
देख लेंगे मैम।
उन लोग उन्हें बाद में
अरे बाद में रख लेंगे।
उनका इमरजेंसी था बाबू।
अच्छा।
Can it be used in RH negative mothers? It's very interesting.
Yes.
Dr. Prashant, can you be a little bit louder?
Can you hear me now?
Yes.
Can it be used in RH negative patients?
Yes, sure. We can use it.
Okay.
Because it is safe to use an RH mother, as I think it does not contain any blood products. Carbetocin does not contain any blood products, so we should not be afraid of that, because any blood products that could cause an immune response in RH individuals. So I think it should be given in RH negative mothers.
One interesting point you brought, madam, in, that in rural settings where facilities are not available, it's straight away better to go for carbetocin, because we may not have facilities for final management.
Yeah.
So it's better to start prophylactic with the best one.
This question, madam was to answer. Can it be used in case of retained placenta? It was unanswered. Yes, madam.
I don't think it has got a great role to play in retained placenta. If the patient is not bleeding and the placenta is retained placenta we say only after half an hour of delivery.
Okay.
So before half an hour have passed, almost routinely some uterotonic is used.
Okay.
So the patient must have received either carbetocin or oxytocin or something she must have reduced. So carbetocin is not recommended for treatment of postpartum hemorrhage or retained placenta, I think. So if the patient has already received some sort of oxytocin, even it may
Yes,
not be
yes.
carbetocin, then I think we should go for proper management of retained placenta instead of giving
Removal,
carbetocin
yes.
if the patient is not bleeding.
Madam, some society says that when you remove the placenta by any method, then after manual removal of
That-
retained placenta, carbetocin may be used.
Yes, that
Like
that
yes.
is something different.
Yeah.
That is
Huh.
something different. Once you
Only
have
after
removed
removal,
and
yes.
if
Yeah.
carbetocin has not been given earlier,
Correct.
Huh, yes,
Correct,
yes, it has been not
correct,
written.
correct.
if it has not been given earlier, then you can give.
Yes.
The next slide, Priyanka. Patient profile where doctors can anticipate PPH and use carbetocin.
I think most of the conditions has already been enumerated by
Described.
Dr.
In
Amita,
answer, yes.
and
yes,
she has already
Huh.
answered that.
The
So
next
next
one, madam.
question. The next question we should go.
Can a doctor use carbetocin for prevention of PPH if oxytocin is used in labor induction? Oxytocin,
I think yes, we can go for it. If oxytocin is used for labor induction and the patient has delivered, we can give carbetocin.
you can give carbetocin.
Yes, yes.
Because oxytocin is almost routinely used in all the second stage.
Yes.
Yes.
Yeah, Priyanka, the next one. Advantages over oxytocin, misoprostol, carboprostol, and ethyl
Carbetocin has got advantage of its stability
Huh.
compared to oxytocin
Correct.
at room temperature and even higher humidity, as well as it has got a longer half-life. And as you have seen in the studies, it has got lesser side effects.
Correct.
And it is more effective and the contraction lasts for longer period of time. So there is mostly no need for repeat the dose. Regarding misoprostol, carbetocin is far better than misoprostol because misoprostol takes time to act and it has got side effects also in the form of nausea, vomiting, rigor, fever. So all these problems are there with misoprostol. So that doesn't let it make the first choice of treatment for any prevention of PPH. Carboprost mostly has been given up because of its side effects like palpitation. It is strong contraindication in any heart problem, bronchial asthma, and all that.
Yes.
And methyl ergometrin is a very notorious drug, I should say, that it leads to so much of hypertension. I don't know how we had been using in the past, but nowadays, even if you give one dose of ergometrin in a case of who is having PPH, the next complication that she does have is rise in blood pressure. So because of that fear, we have given up giving methyl ergometrin.
I was unaware about carboprostol. It's not
Yes. Advantage it's carbetocin has added advantages over carboprost because there is lower incidence of hypertension. Reduce risk of bronchospasm, as madam told.
Yeah,
The same thing is there. Fever GI side effect. Fever is very less and easy administration. That is not in for carboprost. We have to use antiemetic and these are things to prevent this gastrointestinal side effect. So there is definite advantage over carboprost also. So I think over misoprostol, over methyl ergometrin, over oxytocin, all these four drugs, we have certain advantages of carbetocin.
Correct. How do you decide when to give carbetocin IV or IM? Like I saw in your case studies,
Madam had already shown.
Case 1 IM was used, in case 2 IV was used, although both were, is there any criteria where we decide IV or IM?
For IM, routine PPH prophylaxis.
Routinely in vaginal deliveries.
Delivery for prophylaxis.
Because of course, it takes 1 to 2 minutes to start its action, but till then, usually the placenta is not separated, so there is no bleeding. And it takes 1 to 2 minutes, and then the uterus contracts and the placenta gets separated, and the patient doesn't have bleeding. So IM and they are usually the clinician is not there. Sometimes even the IV line has not been put in. So it is very easy to give any IM drug.
Absolutely.
It can be given IM by any of the medical personnel who is attending the patient.
Yes.
IV can be given during cesarean section because everybody is there to look for anything, and we do not wait for such a long time for placenta to get separated.
Correct, correct.
So IV can be given in those situations. Otherwise, IM works well.
Yes, yes.
If the patient is not responding adequately with carbetocin, what additional uterotonics you will use?
That,
Which type of?
yeah, then definitely first line will be additional uterotonics will be oxytocin. Then
Okay,
second, we can think of ergometrin if a patient is no history of cardiac or hypertension.
hypertension.
Isoprostol also can be given. And second line drugs are prostaglandin F2 alpha or E2 like that. And lastly, third line additional uterotonics, that is not uterotonics, but that reduces the blood loss is tranexamic
Tranexamic.
acid that we can use. But important one is we have to monitor vital signs, tone and bleeding closely. And accordingly, we have to think about the other uterotonics. If it simply works after massage, then we don't think. Sometimes it works late and effect comes later on.
Correct,
So we
correct.
should just wait and monitoring, and then we think of other. But first line at uterotonic will be oxytocin.
I get a feel that the use of tranexamic acid is somewhere increasing in
I
people.
think, can I add something?
Yes,
Yeah,
yes, madam. Yes.
Once
Yes.
carbetocin has not responded, the patient has not responded to carbetocin,
Mhm.
then I prefer giving immediately tranexamic acid
Yes,
and sublingual misoprostol.
yes,
Okay.
madam. But
Because
his question was
carbetocin and
uterotonics. That's why
oxytocin are almost have got similar action.
similar thing.
Correct.
Tranexamic acid is given. Yes.
Tranexamic acid and oral misoprostol
Misoprostol
most of the
works.
time.
I think
Yes, yes.
somewhere the use of tranexamic acid is increasing PPH management as
Yes, it
well.
is recommended for the
Yes,
primary
yes.
But it
care
is high. Yes,
and
highly recommended.
treatment
1
Correct.
gram IV and repeat as needed.
And
Whenever
yeah,
it
Even
is
WHO
required.
recommends the first treatment for PPH is
bolus, yes,
tranexamic acid 1 gram slowly, I think. And that works very fine.
very fast. Good, got this. In the next one, Priyanka. Where carbetocin is more effective, we have seen this vaginal vaginal delivery or cesarean section or both. Are any guidelines to support this? I think we have seen this question.
I think it is effective in both,
Both,
equally
yeah.
effective in both.
Yeah. Is carbetocin a reserve drug or should be used as a first line for patient with high risk?
It is nothing like that. It should be given routinely to all the patients
All the
because
patients.
majority of the PPH occurs in those patients who are not been have been
Absolutely.
labeled as high risk for PPH.
Yeah, in fact, you mentioned, the bit that you don't expect PPH and suddenly it comes like
Yes.
out of
Now,
nowhere.
many studies have shown that carbetocin is increasingly being considered as a first line treatment for prevention of PPH, especially in high risk patients. So that it is not a reserve drug.
And especially in the interiors where we do not have too many facilities, use of carbetocin straight would avoid further complications.
Yes.
Yes. The next one, madam. What is the treatment protocol if carbetocin is used and fails? I think
Madam
we have seen
already
this.
answered.
I've
Madam
already
already
discussed
answered.
it.
The next one. What are the adverse effects, side effects, or contraindications, if at all, of carbetocin over oxytocin and other hemodynamic and other uterotonics based on hemodynamic profile? Are there any, first of all, to begin with?
Adverse
Sorry,
side
can you-
effects we have already discussed, and
Yes.
contraindication of carbetocin are only heart disease in the patient,
Yeah, active heart
and
disease.
then it should not be used. And regarding low blood, if the patient has got a low blood pressure on the lower side, it is better to avoid oxytocin and go for carbetocin because it doesn't lead to hypotension.
Minor
And
side
if there is
effects have
fluid
been seen.
retention also, if there is
Yes.
fluid retention, then also carbetocin is better than oxytocin in those situations.
So I think, madam, there are a few contraindications, like if there is hypersensitivity or severe hypertension, cardiovascular disease, or history of placental abruption. Should we go for this in case of placental abruption carbetocin? I think then we should not.
Placental abruption after delivery of the patient. So if there has been, the patient has already delivered and the placenta has been taken out, then I don't think there is any contraindication to.
No, just relative. Sometimes they consider that there may be coagulopathy, so it should be used cautiously.
So that is equally true for any of the oxytocin.
Any of the yes, madam. And whatever the side effects and adverse effects are common to all other uterotonics.
All the other ones.
Yes.
Next one, Priyanka. How would you conclude efficacy, safety, and tolerability of carbetocin vis-a-vis others?
To conclude, I should say that it is effective as any other uterotonics that has been used. Safety profile of this carbetocin is also very good, and tolerability has also not been challenged till date. And let us see what happens in the future, because this is a comparatively newer drug as
Yeah.
compared to oxytocin and
Oxytocin.
misoprostol that has been there for a very long time. So at the moment, I think it's very efficacious, quite safe, well tolerated versus other neutrotonics. It doesn't have any negativity that we have found.
Yes,
Right.
yes.
Thank you. Thank you, Madam. Dr. Singh, thank you, Amita, Dr.
Uh,
Amita, for
yes.
these wonderful insights and our clarity on this. I thank all the doctors who took time from their busy schedule and commitments and attended the webinar. Thank you, marketing team Hetero Healthcare, for conceptualizing and organizing this webinar. Thank you, IT team Hetero, for your support and guidance in all technology-related matters. And last but not the least, thank you, Hetero Healthcare field personnel, for a super coordination. Thanks all of you once again. Signing off. Wish you a very good evening.
Thank
Thank
you.
you, Hetero people, for having organized this.
Yeah,
Thank you.
of course. It was nice.
Thank you so much, ma'am.
It was a pleasure
was-
participating.
Yeah,
Madam, lovely insights we
it
got,
was a lovely session, ma'am. Too
Great
good.
insights we had. Yes.
Too good.
Because
Good,
despite being a doctor, I see books more than patients. So, these clinical insights are